echocardiographic assessment of mavacamten therapy in hypertrophic obstructive cardiomyopathy patient. Before going to my study, I'd like to share some background information on hypertrophic cardiomyopathy. HCM is the most frequently inherited cardiovascular disorder caused by gene mutation in sarcomere, and as many as 1 of 200 adults may have this condition and responsible for most cases of sudden cardiac death in young people. So of all the varieties of hypertrophic obstructive cardiomyopathy, the obstructive cardiomyopathy is the more percentage. And the pathophysiology of HCM include dynamic left ventricular outflow tract obstruction, which is as a result of septal hypertrophy with narrowing of left ventricular outflow tract, anatomic alteration in the mitral valve apparatus, and consequently systolic anterior motion of the mitral valve leaflets leading to left ventricular outflow tract obstruction. So diagnosis of hypertrophic obstructive cardiomyopathy, the mainstay of the investigation are 2D and Doppler echocardiography. We used to do this echocardiography at rest, during Valsalva maneuver, and on standing. And depending on the echocardiography, we diagnose the LVOT obstruction. So what is the treatment modality available for HOCM? Along with the lifestyle measurements, if the resting or provocable left ventricular outflow obstruction is more than or equal to 50 millimeter of mercury with symptoms, the class 1 indication is beta blocker. If the patient is still symptomatic or intolerant, then we go to verapamil or diltiazem class 1, and still symptomatic disopyramid. Another drug, that is the mavacamten, is class 2A indication according to the ESC guideline on cardiomyopathy in 2023. And if still the patient is symptomatic, then we go for the septal reduction therapies, that is class 1 indication. And of course, for primary and secondary prevention, ICD is also considered. So today's drug, that is the mavacamten, which is the class 2A indication, the 2A. So what is the mechanism of action? It is actually a reversible cardiac myosin ATPase inhibitor. What happens in hypertrophic cardiomyopathy at the sarcomere level? There is increased formation of actin-myosin cross-bridge. So when there is increased actin-myosin cross-bridge, this results in hypercontractility, impaired relaxation, and altered myocardial energetics. What this drug does is it causes inhibition of myosin ATPase inhibitor, resulting in decreased actin-myosin cross-bridge formation. As a result, there is attenuated hypercontractility with improved compliance and energetics, resulting in reduction in dynamic LVOT obstruction and other improved cardiac filling pressure and cardiac biomarker improvements. So there have been several trials. Explorer HCM and Valor HCM are two of them. So it is a drug found in capsule form and found in 2.5 and 5 milligram strength, and the dosing is once daily. Echocardiography plays the main stem of investigation in deciding how to initiate the dose and how to follow up the patient. The dosage guideline has two phases, that is a treatment initiation phase and a treatment maintenance phase. The treatment initiation phase comprises of 12 weeks and followed by every 12 weeks maintenance phase. So here we start the patient, those having good ejection fraction, that is ejection fraction more than or equal to 55%. Then we start the patient with 5 milligram capsule once daily. Then we follow up the patient at week 4, and depending on the LVOT gradient, we either down titrate or we maintain the dosage. So in week 8, then again we do the echocardiography, and depending on the LVOT gradient, we decide whether to continue the drug and how to maintain the drug according to the dosage guideline. I'm not going to go through this because this is very complex. So after the 12 weeks of initiation therapy, then we go for the maintenance phase. And here, the patient's ejection fraction is most important along with the LVOT gradient. gradient. Depending on the ejection fraction, if the ejection fraction is less than 50%, we interrupt treatment. We do not continue the drug. But the ejection fraction is more than 50 to 55, according to the dosage guideline, we either continue the same dose or we up titrate or down titrate all the medications. So this is how we do this treatment continuation in these patients. So I'm going to show you a case that we have been following up for the last 12 weeks. This patient was a 65-year-old gentleman who was a known diabetic and a known case of hypertrophic obstructive cardiomyopathy presented to our OPD with shortness of breath. His NYHA functional classification was 3 with occasional palpitations and dizziness. And the patient was having beta blocker at his highest dose, but the patient was still symptomatic. So we did a baseline echocardiography of this patient, and we can see that there is asymmetrical hypertrophy along with the systolic anterior motion of the mitral valve. And also this is the apical four-chamber view showing the SAM, and there is asymmetrical hypertrophy. So at rest, his gradient was 70 millimeter of mercury, and after Valsalva, it was 110 millimeter of mercury. So we decided to go for mavacamten therapy. And as the dosage guideline, we started him on 5 milligram daily mavacamten treatment. So, and we asked the patient to come to follow up after 4 weeks. And on week 4, we did the echo, and it showed that his ejection fraction was 60%, so it's not decreased, and there is partial SAM, but there, if we saw the gradient, and we could see that after Valsalva, his gradient decreased to 36 millimeter of mercury. So again, according to the guideline, as the patient is still over 20 millimeter of mercury, we continued with 5 milligram daily dosage of mavacamten. And then on week 8, we again followed up the patient. This is his second follow-up in week 8. And it showed that there was significant reduction of SAM, and LVOT gradient was reduced. It was less than 20 millimeter of mercury on week 8. So we decided to down titrate the dosage, 2.5 milligram daily. And again, we asked the patient to come at week 12. And the patient, as having the same heart ejection fraction, we continued him on maintenance 2.5 milligram daily. His next follow-up will be after 12 weeks. So my take-home message, we are actually following up around 8 cases in our hospital, and we are going to publish the result. So it is echocardiography is very important in dosage. So ejection fraction and LVOT gradient